Make sure the assignment sheet is going around, okay? All right, guys. We're going to get started with thyroid. And I don't remember what I started first, hyper or hypo? Hypo. Hypothyroid. Okay, so the very first thing you need to know about your thyroid is its location. Right here, it surrounds the trachea. Every book that I have ever seen describes it as butterfly shaped, and as you can see, it is butterfly shaped. So obviously, we're going to start with hypo. So our thyroid is not producing enough thyroid hormones. And just about any problem, and certainly with your endocrine system, you have a primary issue or a secondary issue. When it's primary, it means the actual problem is with that actual organ. So in this case, it would be primary, would be actually involve the thyroid. When it's secondary, it means something else goes wrong that affects it. With secondary hypothyroidism, it's usually your pituitary, because your pituitary is what secretes the TSH, thyroid stimulating hormone. So when your pituitary secretes TSH, just like the word says, thyroid stimulating, it stimulates it to produce its hormones, which are T3 and T4. If the thyroid is the problem, then this has to be taken care of before we can take care of this. But most of what you will see are related to primary thyroid. Your thyroid is your problem. So I'm going to focus on primary, and every once in a while I'll go back to secondary a little bit. I wanted to show you this picture because this is a young lady with hypothyroidism before treatment and then after treatment. What a dramatic difference, huh? What a dramatic difference. So, okay, your hypothyroid process starts on page 500. And the causes of primary hypothyroidism, usually it could be a congenital defect. It can happen, and you need to know this with anything, but I do know that when I was reviewing NCLEX questions for you guys, they referred back to this several times, both with the thyroid and with the adrenal gland, because we're going to go over the adrenal gland too. That when you treat one, you can treat it too much, and it goes in the other direction. So sometimes when hyperthyroidism is treated, it goes too far in the other direction. And one of the treatments for hyperthyroidism is the removal of the thyroid, thyroidectomy, in which case now they're going to be hypothyroid and they're going to need thyroid supplements. Okay? There's also autoimmune. Hashimoto's is the most common autoimmune hypothyroid, and it's the most common cause of a goiter. Iodine deficiency, this used to happen a lot, but nowadays it doesn't happen too often because one of the things that they have done nutritionally is iodize our salts. Iodine is needed for the synthesis of T3, T4. And then we already talked about secondary to our pituitary gland. Alrighty, diagnostics. This is where you kind of need to know a little bit about your pituitary gland. Your pituitary gland sends TSH, thyroid stimulating hormone. When it detects that our T3 and our T4 are kind of low, then it sends our TSH and says, come on, I'm stimulating you, make more. But so when they do this test and our thyroid is not working, obviously our T3, T4 are going to be low because we have high pulse. So what do you think is going to happen with our TSH? It's going to be high because it's trying to stimulate it. So it's sending more, you're not responding. So I'm sending more, you're not responding. So with primary thyroid, your TSH is going to be high, trying to get your thyroid to do its job, and our T3 and T4 are going to be low. I'm debating in my brain whether to tell you this or not, because there's very few questions that I have ever seen related to it, but there are a few. So I'm just going to kind of go over it. If anybody has any trouble, we'll talk about it at the end. When the main problem is your pituitary gland, then your TSH is what stimulates your thyroid to work, so then your TSH is high. And because it's creating too much T3, and it's overstimulating it. And if your pituitary is causing the hypothyroid, then your TSH is low because it's not stimulating it enough. Okay? Now let's focus back on secondary, which is usually what you get a lot of questions about, which is the problem is here. So when the problem is here, this tells you you've got T3, T4. If they're low, then your TSH is going to be high because it's trying to get it to do more. Okay? So let's keep that in our brain. If you ever get asked another question, okay, so you just have to accept that if you don't understand it, you're going to miss that one question. Okay? Or we can stay afterwards and go over it. For right now, what you need to focus on is primary thyroidism, which means our T3s and our T4s are low. Hypo. And so our poor pituitary is trying to get it to come back up to normal. So it's sending TSH, thyroid stimulating hormone, trying to stimulate it and stimulate it. So in this situation, our TSH would be high. Okay? All righty. Other tests other labs that are done because it affects our hypothyroid is our LDL. They tend to be increased. Our cholesterol levels tend to be increased. Now you have to remember that with hypothyroid, everything seems to slow down, and you would see anemia, potentially hypoglycemia, and hyponatremia. Okay, so now these are the lab results of your case study that Ms. Fran has for you. So let's put together what we just said. Number one, we're going to look our TSH. Look at our TSH, high, because it's trying to stimulate our thyroid to create T3s and T4s. Look at our T3s, low, T4s, low. Okay? Now look at our sodium, low. Our potassium is borderline, and our glucose, oh, it's okay. It's okay in this particular patient, which is good, And I think an important thing to recognize here is I put down the clinical manifestations that can be seen, but it doesn't mean that every single patient is going to have every single thing, okay? But then, because you are critical thinking nurses, if this patient has hypothyroidism, you would be monitoring the glucose, and you would be assessing for signs and symptoms of hypoglycemia. There you go. Good job. Okay, assessment of your case study. Overall, your case study symptoms unremarkable except for slow, deliberate speech. This is the case study. Hoarse voice is hoarse, hands swollen, face puffy, skin dry and flaky, decrease in alertness. So now let's look at the basic things that you need to look at with hypothyroidism. Number one, classic cold intolerance. Hypothyroid, think of a sluggish person. They tend to get cold easily. They have thinning hair. A big one that you get asked about is this dry skin. brittle nail, and I don't see it, but another, yeah, here it is. Constipation. Constipation. Now think of sodium, because they tend to have low sodium. So then where sodium goes, water goes. So they don't have that moisture, and they tend to be dry skin, constipation. Okay? Notice here we have thickened skin, slowing down, bradycardia. Bradycardia. The other thing that you probably need to remember, weight gain, because their metabolism rate is slow. And when you think of people with hypothyroidism, that's one of the first things that would be obvious to you. And the patient would tell you, I've been gaining weight and I can't control it. While hyper, they're losing weight. Okay? So note, enlarged thyroid is also a manifestation of hypothyroidism. Why do you think? We usually correlate it with hyper, but we do see it with hypo. Why do you think that it is a manifestation of hypo? Trying to compensate. So trying to make more T3, T4. And symptoms of hypothyroidism are often confused with symptoms of aging because of that slowing down process. Especially if you happen to be an older person, which thyroids do tend to give people problems as they get older. Once again, I want to point out the dry, okay? Dry hair, the thinning of the eyebrows towards the end, at the lateral part, the periorbital edema, and the puffy face with weight gain. Okay. All right, medication. The classic medication that we give this patient would be Synthroid. Levothyroxine. Classic. Because we are replacing, what are we replacing? T3, T4. Because what is wrong with, what is our level for TSH? High. Very good. With hypothyroidism high. So, with thyroid medication should be taken on an empty stomach in the morning. Most of your endocrine medications are taken in the morning to mimic our normal cycle. Okay? I want to point out that empty stomach, usually it's best. In fact, my mother takes levothyroxine, and she wasn't diagnosed with hypothyroidism until I think like 80, way late in her life, and she's going to be 86. Anyway, for her it's easiest to get up and take it right away. And that way she won't forget, her stomach is empty. But you should know that empty stomach could also be 2 hours after a meal. But for this one, it's better to take it first thing in the morning because you want to mimic the cycle of your thyroid gland. Also, if you can think that hypothyroidism, you're sluggish, hyper, you tend to be, like the word says, hyper. So you don't want to take this medication later in the day because it could create insomnia. It could. Okay? You want to take the pulse. You want to instruct your patient to learn how to take her pulse, his or her pulse, during medication modification, because what is the classic symptom of hypothyroidism related to the heart? Bradycardia. So if you're taking this medication, what do you expect the side effect to be? Tachycardia. So you want to be assessing. You want your patient to assess. Remember that I told you in the past, when you take a medication to fix one thing, the risk is over-fixing it. Okay? This drug, Synthroid, levothyroxine, can potentiate, means increase the effect of warfarin and digoxin. Are you okay back there? Yeah. Okay. All right. can potentiate the effects of warfarin and digoxin. With diabetes, closely monitor blood sugars, because what is the concept, the manifestation of hypoglycemia? Very good. Okay, do not use iodized salt or over-the-counter drugs that contain iodine with this specific medication. And your patients need to know that this is a lifelong therapy. My mother always asked me that. How much longer? For the rest of your life, Mom. Oh, for the rest of my life? Yes, ma'am, for the rest of your life. Okay, let's talk about our nursing diagnoses and interventions. Number one, decreased cardiac output. Remember that their heart rate tends to be bradycardic. So if you have a slow heart rate, your cardiac output formula is heart rate times stroke volume equals cardiac output. So they have a tendency to have a decreased cardiac output. So you would want to be monitoring and assessing their cardiovascular status. What's the best way to do that? Vital signs. Vital signs. Avoid chilling. Remember that they have cold intolerance. Remember that little picture of that man chilling? Okay, they have cold intolerance. So you want a warm room temperature. If necessary, provide blankets. Alternate rest periods and activity, especially when they're getting used to their medication. Remember that they're prone to constipation. So what do we do for constipation? Increase fluid intake. Classic. Once you guys know your basics, everything else just falls into place. So constipation, increased fluid intake, high fiber diet, and of course, still activity. But remember to alternate with rest periods, because while they're getting adjusted, they are very lethargic and run down. Risk for impaired skin integrity. Why are they at risk for impaired skin integrity? Dry skin, exactly, dry skin. So you're going to teach them using emollients, stuff like that, to keep their skin moisturized. Let me see if I left anything out from your book. Probably the only other thing that I can tell you is a lot of teaching to your patients. Okay, if the patient doesn't get diagnosed or doesn't take their medication, they are at risk for Myxedema Coma. So you need to remember that this is a life-threatening complication of hypothyroidism. So if we already knew that somebody with hypothyroidism was at risk of hyponatremia and hypoglycemia, obviously if they are in a life-threatening situation, they would have life-threatening hyponatremia, life-threatening hypoglycemia. We already said that they were tending to be cold, so now life-threatening hypothermia. Lactic acidosis because of the lack of sufficient glucose for metabolic activity. And the big one probably should be way at the top, but I wanted you guys to put your thinking caps together and in order, would be cardiovascular collapse. Cardiovascular collapse. So when we talk about cardiovascular collapse, what are we talking about? The heart. The heart. So we already have the bradycardia, even slower, potentially, life-threatening slow, and low blood pressure, right? So causes, they don't take their meds. Notice this one. Exposure to cold temperatures can create this. And this is important for you guys to remember as nurses. CNS depressants. These patients are very sensitive to CNS depressant. Give me a CNS depressant that we give routinely in the hospital. Opioids, right? So on a patient with hypothyroid, you would give it very cautiously, okay? Because they could go into myxedema coma. Treatment. First, treat the underlying cause. right? What is the underlying cause? And then, of course, in the meantime, while you're trying to figure out what your underlying cause is, ABC, because it is life-threatening. So anytime anything is life-threatening, you reverse back to your airway, breathing, circulation. Which with this one, the circulation, because of cardiovascular collapse, is going to be a big one. Okay? So maintain fluid, electrolytes, acid-base balance. Let's warm them up. Let's warm them up. And let's give them the medication that caused this in the first place, thyroid hormone. Okay? And you can give levothyroxine. There is an IV preparation for that. Now let's look at hyperthyroidism. So now with hyperthyroidism, our metabolic rate is real fast. So if our metabolic rate is real fast, we're going to be sweaty. We're going to have palpitations. The opposite. The other one was bradycardia. This one is hyper. Shortness of breath, rapid bowel movement. A classic sign of our hyperthyroidism is the eyes. What do we call these kinds of eyes?
Exophthalmos.
Exophthalmos. The bulging eyes. Graves, by the way, is a complication of hyperthyroidism. Like we had Myxedema Coma, we have Graves. Well, actually, it's a type of hyperthyroidism. And I'm going to talk, here it is. It's a type. So Patho, we have increased circulating levels of thyroid hormone. So what do you think your TSH is going to be? Low, because it doesn't want to stimulate it more, right? So it's going to be low. Graves, just like we had Hashimoto for hypothyroidism, Graves is your autoimmune hyperthyroidism. It is the most common cause of hyperthyroidism. It can also be a result of neoplasms, toxic multinodular goiter, where you have a goiter that's producing too much T3s, T4s. Thyroiditis and inflammation of your thyroid. Side effects of certain medications or over-medicated with thyroid medications. They don't know, that's why we have the little boxes for people so that they know Sunday, Monday, Tuesday, and they don't like. My mother would potentially do that, I know. It's like, did I take it? I don't remember. I better take another one. She would. I know that. So anyway, all of these things can cause hyperthyroidism. There's something that's not there, but I guess it could fall under side effects because my nephew ended up with hyperthyroidism, and that was a result to side effect of radioactive exposure that resulted in causing like a thyroiditis for him. And he ended up having a thyroidectomy. And I have an ex-daughter-in-law that came down with Graves' disease. And I was shocked. I was really shocked. Bless you. She's very young, but the first time that we were having a gathering, and she was like, "Oh my God, I'm so hot, and just blowing and blowing. I can't sit still. I'm like, what is wrong with her? I really did think she was on something at that time. I really did. But it turned out to be she has Graves' disease. Poor thing, because she was all over the place that day. So anyway, clinical manifestations. Notice the difference. The other man was all covered up. This one is hot, and she could not cool down no matter what. Increased appetite, weight loss. Now remember, the other person had constipation. This one has diarrhea. Cold intolerance, heat intolerance. Think of a metabolic rate. The other one is slowed down. This one is increased. Insomnia. The other one had bradycardia. This one has tachycardia. You might, oh, you have a chair? Okay. Emotional liability. Now remember the other one was dry? This one is sweaty. So they often describe their skin as moist and smooth. The other one is dry and rough. Okay? Fine here. So when you look at this, you have the enlarged thyroid, which is the goiter, but remember you could have one with hypo. The bulging eyes, which is called exophthalmos, tachycardia, systolic, increased systolic pressure, weight loss, diarrhea, tremors, and one of the other things that they ask you about is the emotional lability.
I noticed it says finger clubbing also. Is that, do they tend to be hypoxemic then?
Probably would have to because that's the only cause that I know related to the finger clubbing, and maybe because of increased oxygen uptake because of the increased metabolic rate. Okay, diagnostic tests, once again, they would do the TSH. What would we expect our TSH to be? Low, because our pituitary is saying, I'm not going to stimulate you anymore, you're already producing too many. What would we expect our T4 or T3? They usually do them together. High, very good. They also tend to do a radioactive iodine uptake because of the effect iodine has on the synthesis of T3, T4s. And here would be your results. Decreased TSH, increased T3, T4 levels, and high uptake of radioactive iodine, because iodine will be taken up by your T3, T4 in any form.
Another question. I noticed the first one, it says it's a blood level, but the second one is not a blood level. So is that like in the urine or something? The T3, the free tetraiodide?
No, they're usually in the blood.
They're all blood?
Okay. And I'm missing.
Oh, the thyroid test right here. Yeah, so I was wondering. If
no, they're both, they call it a thyroid panel. What about the FSH? No. Don't get that confused. FSH is follicle stimulating hormone, and that's...
But when they're testing your TSH, your T3, your T4, and your FSH for different...
Did I put FSH?
No, you didn't. I'm just reference to it.
Maybe because they have amenorrhea, is that...
Right, and that could be related. I personally can honestly tell you, I don't know that they would go test that, because if they determine that it's thyroid, that's what's causing the amenorrhea. When they would do an FSH, it would be like somebody that they're thinking of the reproductive system.
Right, like they do it on males too, in different situations for different characteristics that males notice it. For increased testosterone levels and stuff like that.
Right, because reproductive.
Right.
But if they find out it's your thyroid, there's no need to go there. Does that make sense? Okay. All right. The medications given for hyperthyroidism. First one, you need to be aware of your iodine preparation, which are Lugol, SSKI are the most common ones. And these are iodine preparations. How do they work? They inhibit the thyroid hormone synthesis, and it makes a hyperplastic thyroid less vascular. It is important to remember this part, the less vascular component, because when they are going to prepare a patient for surgery, like a thyroidectomy, they will give them an iodine preparation to make it less vascular. What is the goal if it is less vascular?
Bleeding.
Less bleeding. Less bleeding. Mija, I don't know if you want to sit over there or get some chairs from outside. Okay? All right. The thing about it is that it doesn't taste very good, so people are encouraged to take it in water or in juice. You should monitor for bleeding because it does increase the effects of anticoagulants. And this is not a long-term treatment. Not a long-term treatment. The other anti-thyroid drugs that are used are methimazole, carbimazole, and one of the most popular ones is PTU. PTU. And your book has the long generic name. I didn't want to, I already was running out of space, and it's hard to pronounce, so it's PTU. But you can look at your long generic name. That's probably one of the more common anti-thyroid drugs, PTU. With this one, you need to make sure that you monitor your labs, especially your neutrophils. Now remember, your neutrophils are your first line of defense from your which cells? White blood cells. White blood cells. You need to monitor for signs and symptoms of hypothyroidism. Now with hypo, when you start treatment, you monitor for signs and symptoms of hyperthyroidism. So you would be monitoring, the patient has been losing weight with hyper, are they gaining weight? Gaining weight. Monitor for bleeding, and the same thing as with your other one is administer at the same time daily. We want to mimic the natural effects, we'll control and to get the natural effects of our thyroid.
So this one you take it with meals?
Yes. Good thing that you point this out. This one is with meals, and the other one is on an empty stomach. An empty stomach. Now remember that with this one, hyperthyroidism, one of the symptoms is palpitations, rapid heart rate. If your heart rate is too rapid, it will have the same effect with your cardiac output. It will drop. Why? It doesn't have time to fill. It's just going crazy, crazy, crazy. So with this one of the common drugs that they use is a beta blocker. And the most common one is propranolol, to slow down our heart rate. Propranolol? No. This is a beta blocker. You might be thinking of your benzodiazepine. Oh, propofol. Oh, no. Totally different. Totally different. Yes, propofol. The Michael Jackson drug. No, this is not the Michael Jackson. It's good that you even thought about it so people that are confusing that in their brains can get it straight. This is what? A beta blocker. A beta blocker.
For the anti-thyroid drugs, do the peak and trough for them? So you're giving it at the same time daily to make sure you have like a
We don't do peak and trough. Well, would we monitor blood levels? Yes, but not peak and trough. Most of your peak and troughs are done with, which is an antibiotic. Because you want to know your trough before you give the next dose. And with this, you monitor blood levels to make sure that you are getting to the desired level. Okay? All right, other treatments that they do for thyroidism, the radioactive iodine treatment. Think about the word radioactive. It damages the thyroid cell, so it is no longer hyper-secreting thyroid hormones. With radioactive iodine, think about the word radioactive, because you would have to do all of the precautions that you would do with anything that is radioactive. For example,
stay away from people.
Stay away from people, especially
babies,
children, pregnant women. Exactly. Children and pregnant women are the big ones, right? You can take the radioactive iodine orally. You could do that orally. They've also been known to do an implantation, which is not there. But notice, the patient needs to have a pregnancy test. If they are young and of childbearing age, they need to be told of the risks of getting pregnant. Stay away from getting pregnant. Stay away from getting pregnant. And assessed for hypothyroidism. Hypothyroidism.
I have a question. The return infection is due to
decreased neutrophils. Wait. Now let me think about it. You made me think, and that's good. I like to think.
That was one of the ones you listed.
Yes, but it's not a decreased neutrophils. You see an increased neutrophils. Let me go. You know what? Because I don't want to waste time. Let me look it up right after. But put it down. I know you won't let me forget. Okay. All right. Okay. Now, one of the very common treatments, and this is what my nephew went through, was a thyroidectomy. They just removed his thyroid. Okay? Now, pre-op, you're going to administer the anti-thyroid drug because you're going to be manipulating it. So they want your thyroid as close as possible to what is described as euthyroid. What does EU? Euthyroid. Normal. As close as possible to normal levels before they go in and manipulate it where they can excrete and release a lot of hormones. Okay? They're also going to administer iodine because decreased vascularity. You're going to teach the patient, now remember we're pre-op, teach the patient to support the neck because these stitches are here. We don't want them dragging it up like that. Support the neck and expect a degree of hoarseness. Okay, a degree of hoarseness. Now post-op, obviously they're manipulating right here. So one of the big things that you would be monitoring for is airway breathing. You should have a tracheostomy tray at the bedside. Because of that airway breathing compromise, a lot of these patients go to ICU for maybe 12 hours, 8 hours, overnight stay. And one of the things that we always knew who was getting the tracheostomy patients, thyroidectomy patients, because we put a tracheostomy tray there when we were preparing our rooms. Oh, you're getting the thyroidectomy because you would see the tracheostomy tray. So it was just in case. We're going to assess for hemorrhage from that side. Remember to support the neck, especially when they're still very groggy. And we're going to assess for laryngeal nerve damage. Well, if you have a laryngeal nerve damage, it goes past hoarseness, right? It goes past hoarseness, and they may not be able to speak. The big thing, besides these things that you get asked about, this and the tetany. Why would you suspect tetany when somebody has a thyroidectomy?
The parathyroid.
The parathyroid. They're P-shaped there's 4 of them on each side of the thyroid. So they usually come out. It's inevitable. And what is the job of your parathyroid?
Regulate calcium.
Regulate calcium levels. So if they're gone, this patient is at risk for hypocalcemia. So you would be monitoring your ABCs and hypocalcemia. What are the signs and symptoms of hypocalcemia? What is this one? Chbosky, Trousseau, tremors, right? The little saying, some tingling. The little saying, most of it is related to muscular, irritability. The saying that I learned when I was studying for my CCRN was twitch, that's the twitching. Twitching. Twitch, these, Chbosky, and Trousseau. As long as you remember that irritability, and the 2 that you get asked the most, besides the twitching, the numbness, the tingling, not numbness, tingling, is the nursing assessment, which is the Chbosky. And I am finding, I always used to think up here in the cheek, but when you look at your book, they describe it in front of the ear. Okay? Chbosky, and then the blood pressure cuff for the Trousseau. Nursing interventions, risk for decreased cardiac output, monitor the vital signs, remember a cool, calm environment. And remember I told you a rapid heart rate is not necessarily going to keep your cardiac output up. Either one can bring your cardiac output down. Disturbed sensory perception. Remember the visual components? That is a big one to take care of those eyes. It's bad enough that they're going to have their that they have had their thyroid removed. You don't want to cause, because you didn't do protective measures to protect the eyes. Remember that they have the exophthalmos. We want to protect their eyes. Imbalanced nutrition, less than body requirements. Remember that these people tend to lose weight, daily weights, monitor labs, and then disturbed body image and anxiety. It looks real bad initially, and I can understand, especially females, really being disturbed about their body image, but it gets better. It does get better. But you have to give them support in the meantime. Thyroid crisis. Remember that with hypothyroidism it was Myxedema Coma? With this one, it's called thyroid crisis or thyroid storm. The causes: untreated hyperthyroidism or stressors, such as infection, trauma, untreated PKA, surgical manipulation of a gland, this gland. And this is why you want it euthyroid when they're getting ready to take it out. Okay? The manifestations, look at the manifestations. Fever, anywhere from 102 to 106. Scary. Tachycardia, dyspnea, systolic hypertension. Looking at these two, what would be a good drug for this patient? The beta blocker, right? The beta blocker, good job. Agitation, tremor. What do we treat? ABCs, airway, breathing, circulation, stabilize cardiovascular status of your patient. Beta blockers is one of the ways to help stabilize it. Cool your patient down and replace fluids, glucose, electrolytes. They're using up a lot of glucose. They're just losing it away because of the hypermetabolic rate. And your electrolytes. All right, let's get to our questions and then we'll go to the adrenal gland. An agitated client is admitted into the ER with dyspnea, intermittent chest palpitations. The client has a blood pressure of 170 over 110, heart rate of 130. The health history reveals thinning hair, recent 10-pound weight loss. What's your brain saying already? Hyper. Good job. Increased appetite, fine hand and tongue tremors, smooth, moist skin. A physician writes orders for the client. Which orders should the nurse implement first? Who says 1? Who says 2? Who says 3? Who says 4? Who doesn't know? It is 2. It is 2. Cardiovascular. The nurse should first administer propranolol as ordered by the physician. Propranolol is a beta-adrenergic blocker for sympathetic relief of the thyrotoxicosis and decreasing peripheral conversion of T4 to T3. It controls cardiac and psychomotor manifestations within minutes, because you can give it IV. A beta blocker is also a first-line treatment for a client with acute coronary syndrome. When I was reading this, I was looking back and I was thinking, well, yeah, because if you're not sure, you have elevated blood pressure, you have 130, you have a patient that's dyspneic, so they could be thinking ACS, and that would work for both. Dysrhythmias can occur from beta-adrenergic receptor stimulation caused by excess thyroid hormone or following an acute coronary syndrome. PTU will inhibit the synthesis of thyroid hormone. Clinical effects may be seen as soon as 1 hour after administration. Decreased TSH and increased T4 confirm the diagnosis of hyperthyroidism. Increased cardiac enzymes would confirm the diagnosis of ACS. So while all of these would be done, this one would be your priority. Okay? A clinic nurse is teaching a client diagnosed with hypothyroidism. Which instructions should the nurse provide regarding the use of levothyroxine sodium or Synthroid? Select all that apply.
I don't know what color your clinic is under. Oh, they're 100. Is that your limit? Yeah. Mm-hmm.
All right. How many say 1? 2? I hope I have more 2s.
Oh, yeah.
Pulse rate. Obtain the pulse rate before taking the medication. 3?
Well, that's already going to happen, right?
If it's not enough, then.
4?
Yes, 1.
5? Okay. The only problem I had with 1 is that it doesn't say in the morning, but you have to assume that everybody is going to get up at a reasonable hour to take breakfast in the morning. So maybe I was thinking too much into that, but that was my only problem. But it did say breakfast, so the assumption is it's in the morning. Taking the medication on an empty stomach promotes regular absorption. It should be taken in the morning to mimic normal hormone release and prevent insomnia. During initial dose adjustment, tachycardia could indicate a dose that is too high, so we would always take our heart rate before taking it. The replacement hormone is used in primary or secondary atrophy of the gland after a thyroidectomy, after excessive thyroid radiation, after administration of anti-thyroid medication, or in a congenital thyroid defect. I heard somebody talking about this. Weight gain and cold intolerance could indicate that the dose is too low. Alopecia may indicate the dose is too high. T3 and T4 should rise with treatment. That is our ultimate goal. Okay, question number 3. A female client is being treated with radioactive iodine therapy for enlarged thyroid gland. The client asks if there are any precautions that are needed during RAI therapy. Which is the nurse's best response? Right away, you would have to rule that one out, right? No precautions. That's a dead giveaway right there. Absolutely true. I'm not going to read it all because we're already at 10:19 in the morning, but absolutely true. 4, you assess a patient with a newly diagnosed hypothyroidism as having an enlarged thyroid gland or goiter. What physiological process causes this enlargement? 3, and this one I actually got right out of your book. Right out of, so what that tells me is look at your questions in your book. Okay, this is a compensatory but ineffective effort to produce more thyroid hormone by enlarging the gland itself. All right. Remember, a safe patient is safe nursing license, and you are all here. I like this one. I like it. I wish for no housework, no cooking, no cleaning, less work, and more money. Poof! She becomes a man. Okay, let's see. All right, so I guess, Priscilla, you need to get us back in here, I guess. Because that's the end of that one. Hello, Priscilla? I guess this gives you a few minutes to maybe get some more chairs, get some more stuff. Is the sign-in sheet going around? Can it go around, guys? All right, guys. Now let's do the adrenal gland. Oh, Priscilla. You're welcome. The adrenal gland. Where are the adrenal glands, guys? Right above each kidney. Right. Where are our kidneys? Costal, vertebral angle. Right. Right. Okay. All right. So with this, with the adrenal gland, we're going to basically study two different types of disorders: Cushing and Addison. So with Cushing, the way I tell, because students always have a hard time with it, and if you can think of Cushing's, okay, a chronic disorder where the adrenal cortex produces excessive amounts of circulating cortisol or ACTH, more common in females, and that excessive cortisol also causes weight gain, the moon phase, and so think of Cushing, okay? Too much, because people get confused. Too much, and the weight gain, the moon phase, the buffalo hump, okay? The central obesity. So, Cushing. What causes it? It can be medically induced. It can be a pituitary tumor, once again. Ectopic forms, certain cancers such as small cell lung cancer create too much cortisol, or where it is in the first place, in the adrenal gland. So let's look at our, you know what, I'm not going to read your case study because it's going to take a little bit too much time. But I put it here, plus you also have it in Ms. Fran's PowerPoint. So you can use your critical thinking to put the two components together. All right, so we have Cushing. Clinical manifestations: fatty deposits, the central obesity, so think of Cushing, buffalo hump. Now, these people have a tendency to have protein and vitamin imbalances, and those imbalances cause muscle weakness and wasting, especially the extremities. Look at the obesity is central, and the extremities are flaquitos. See that? Muscle wasting. They also tend to have thinning of the skin, which results in, because of the weight gain and the thinning, abdominal striae. What is striae? Stretch marks. Bruising, poor wound healing. Also, their bones become porous, which puts them into osteoporosis. And here we have somebody with a fracture. Now look at their electrolyte imbalances. Hypokalemia, hypernatremia. I put them there side by side because not always, but as a rule of thumb, they are inverse. If your potassium is low, your sodium is high, or vice versa. So that way you could remember that with Cushing syndrome. Now, remember I said where salt goes, water goes? So we have hypernatremia, means they're retaining sodium. So what would you expect this person to be? Retaining water, therefore edema. More adding to the Cushiness, okay? Hyperglycemia. Well, what are your classic symptoms of hyperglycemia? Polyuria, polydipsia. These people, because of the increased cortisol, are also at risk for gastric ulcers. Remember, with steroid therapy, that's one of the risk factors, gastric ulcers. Or gastric ulcers have a higher risk with steroid therapy. Okay? And emotional instability. Your case study is unremarkable except for the following: notable round face, significant facial hair, also known as hirsutism, skin thin and bruising to arms and hands, hyperpigmentation in some areas. The hyperpigmentation is caused by the cortisol level. Spotted hyperpigmented gingiva, the gum. Dorsal cervical fat deposits. Where are those?
Okay. Oh,
Dorsal cervical. The buffalo hump. The buffalo hump. Abdomen protuberant, striae, and bruising. Muscular atrophy to all four extremities. That poor baby, she has exactly what the clinical manifestations are. Medications, she's on ibuprofen and multivitamins. It's not a good thing that she's on ibuprofen because that increases the risk of the gastric ulcers, yes. Okay, complications of untreated Cushing syndrome. Well, remember we said hyperglycemia, that's why they would have the polydipsia and polyuria. So obviously, if you don't get it treated, you're going to get very hyperglycemic. Remember we said they retain sodium, which means they retain fluid. So if they retain fluid, what's going to happen to their blood pressure? Hypertension. Then they're going to have decreased potassium. So what's something that you could also see because of decreased potassium? Cardiac dysrhythmias. Very good. I love the way you guys are putting it together this morning. And I don't even have candy. Okay. Increased cholesterol and triglycerides. All I can tell you is it's related to the cortisol, but to try to remember it with your Cushing, think that they already have central obesity. Okay? So you're going to have increased cholesterol and triglycerides. Emotional disturbances. If you can think of steroids, that is one of your classic side effects of steroid therapy, is emotional lability. Okay? And then these people also have an increased risk for compression fractures secondary to osteoporosis. Remember the picture? Remember? There you go. Okay. So now, look at our case study. What about your case study worries you?
The blood pressure.
The blood pressure. Why do you think she has high blood pressure? The sodium and the fluid retention, and because she obviously, you put everything together, is going to end up being diagnosed with Cushing. Okay, diagnostic treatments. For the diagnostic treatments, they do a dexamethasone test, suppression test, because dexamethasone suppresses ACTH. I'm going to let you read that, and then after you read it, because it's a little bit confusing to explain just like the TSH, the T3, T4s with primary and secondary hyper and hypothyroidism. So if you can read it, and then if you want to, I'm going to be here to help you understand it. But what I think you need to remember is that if you're now what is dexamethasone?
Steroid.
It's a steroid. It's a corticosteroid, okay? Like prednisone. If it's positive, then they want to do urine-free cortisol to see how much cortisol is being spilled in the urine. Okay? I think that's what I would probably remember the most. Now, yes, ma'am.
With the medication, is this a steroid? Will it cause the same effect as Cushing syndrome, but in this case it's caused by the adrenal gland? Suppressing the ACTH, will it cause the same symptoms by giving the medication to zero?
I do, and it does, and that's why you have to read, because they're trying to figure out if it's primary or secondary, if it's coming from the pituitary or the adrenal gland. And if it's positive, then they do the urinary-free cortisol. They can also do a CT scan or MRI of, they could do the pituitary or the adrenal gland. Okay, medications. The medications are primarily for cancer or tumor-related issues. So, lidocaine suppresses adrenal cortex activity because Cushing's is too much cortisol. I'm not going to try to pronounce this drug, but the one that I know is used commonly is ketoconazole. Now, ketoconazole is interesting because ketoconazole is actually an antifungal. But unlabeled use is that it can be used because it will also suppress cortisol synthesis. So you do see patients with this. Untreated is another hormone secreted by the pituitary gland, and it suppresses ACTH, but this is a synthetic form of Untreated. Of course, there's always the, let's just take the adrenal glands out, right? So they can remove, here's your adrenal glands. They can remove one or both. But it could be caused by the pituitary. So then they could remove the pituitary gland, which is known as a hypophysiectomy. And they can remove the pituitary through a craniotomy or transsphenoidal through here. Yeah, to get back here. I know. And I've seen horrible spots, but there are certain horrible things in my life, but there are certain things that the mere mental picture of it just does, right? So obviously, just like with your hyperthyroidism, where they remove the thyroid, these people are going to have lifelong treatment. With the hyperthyroidism, it's going to be thyroid hormone. With this one, it's going to be your cortisol hormone replacement. Okay? Now let's look at our case study. Look at her sodium. So what would you expect with her potassium? Low. And there she is. Now look at our glucose. Remember hyperglycemia? And I think what Ms. Fran does with her case studies is awesome because it helps you prepare for test questions. Instead of just memorizing, this is the patho, this is the clinical manifestations, these are the meds, these are the nursing interventions, you actually have to put it together. So now look at your cortisol, because remember it's too much secretion. So look at your cortisol, 73. Adrenocorticotropic hormone, also elevated, 290. What about your ABGs? What do you see with this one?
Alcohol.
Barely, but yes, right? Okay. Then they did the urinary free cortisol level. And look at how much this person has. Okay? I was going to look up the relationship with testosterone and Cushing's, and I know it affects the hirsutism and other, but I can't explain the process. But obviously it elevates it because, first of all, you see your lab results, and second of all, that's what causes the hair growth. Okay, look at your neutrophils. They're elevated. Lymphocytes are a little bit down. By the way, these are all components of what?
White blood cells.
White blood cells, yes. These are all your different components from last lecture, remember? Mm-hmm. So when you get these, it's because they did a CBC with DIF, because they're differentiating your white blood cells. Okay? Alrighty. So nursing care and interventions, one of the most common ones is the adrenalectomy. We're going to remove the adrenal glands, 1 or 2. These people need to make sure that they have a dietary consult because remember that they have protein and vitamin deficiency. So remember, that's one of the reasons they have the wasting of the muscle and they have the skinny arms and legs. So you need to make sure that they're going to have a dietary consult. The vitamin deficiency tends to affect wound healing. So you really want to address these before surgery. Like with any other surgical patient in sinus spirometry, turn, cough, and deep breathe. Remember that they are at risk for an infection. So medical and surgical asepsis. And for those of you that have been coming to my A's, you know how much I stress asepsis. Big time, because of hospital-acquired infections. It is critical. Okay, you're going to monitor the labs. You're going to monitor what? Glucose and electrolytes. Prior to surgery, what do you expect your electrolytes to be?
Normal.
We want them to be normal, but before they get normal, okay, let me rephrase that. With Cushing, what do you expect your electrolytes? The potassium is low. The sodium is high. Think about the sodium carries water, and they're cushy, the edema, okay? And what do you expect your glucose to be? High. Very good. Okay, so what would be our nursing care and interventions? Well, the most obvious would be your fluid volume excess. So anytime you're dealing with fluid volume, you always want to weigh your patient. Absolutely. What is your ratio? What is your ratio of weight gain to fluid volume retention? 1 to 1. 1 liter to 1 kilo. Exactly. You're obviously going to monitor vital signs, assess for edema. Now remember that they started with the fluid retention, and we're trying to get their electrolytes back to balance. So it's going to take a while for all of that to leave tissue and stuff. Yes, Gilbert?
Would you also monitor for shock?
Because they're leaving, yes, you would. Right here. Vital signs. That's going to be your post-op. Vital signs is going to be, and that's why it's called vital. It's going to be your first sign of issues, because that vital signs include respiratory, which is your airway breathing, includes blood pressure and heart rate, which is your circulation. Okay? All right. Fluid restrictions. It's not uncommon for these people to be on fluid restrictions, but of course your vital signs are going to determine that. Risk for injury, environmental safety, the environment. Risk for infection. Remember that these people are at risk for infection. So private room, limit visitors. Once again, asepsis, medical and surgical asepsis, Intake of protein, vitamin C. Remember, what does protein do? Heal, builds and repairs. If you can remember that little thing with protein, builds and repairs.
When you were mentioning the white blood cells in the previous one, so they're not per se neutropenic, but I mean, you could consider them. Do you wear a mask when you're going into the private room, or you don't go to that extent?
To my knowledge, no. To my knowledge, but the thing that would drive it would be your lab results. That would be your clinical judgment based on your lab results. Okay, because you do know that they are at a greater risk for infection. Intake of protein, vitamin C, and vitamin A, because we know vitamin C is very effective and for the wound healing and the immune system, right? Protein builds and repairs, and once again, disturbed body image depends where they went in. Usually, they go in from to the side, and it's a huge incision. Okay, Addison. So if Cushing is too much cortisol, Addison is not enough. So Addison's, adrenocortical insufficiency, a disorder resulting from destruction or dysfunction of the adrenal cortex, which results in chronic deficiency of cortisol, aldosterone, adrenal androgens, and it is more common in women. So what causes Addison? Autoimmune dysfunction, leading to the adrenals, such as secondary to trauma. Remember where their location is, up here. Sepsis, anticoagulants, adrenoleukodystrophy. And I looked it up yesterday and it slipped my mind right now. It slipped my mind. Adrenoleukodystrophy. Oh, that's the genetic one. An X-linked disorder characterized by an accumulation of it's a genetic component. ACTH deficit, and I want you to pay special attention to the last one, because we always teach you that when somebody is on corticosteroid therapy, they don't stop it, right? They're weaned off. Abrupt withdrawal of long-term high-dose steroid therapy, because you can throw them into Addison. Okay?
That's reversible, though, if you start from back to front.
Oh, absolutely. Absolutely. And that would be a treatment. That would be a treatment. Clinical manifestations. I think when I redo these for the next 6th semester group, I'm going to do it in this format because I like this format. So it links the problem to the manifestation. So remember that with Addison's we have increased ACTH and decreased aldosterone, which is your sodium balance. So therefore you have decreased sodium. Remember with Cushing's we had hypernatremia. With Addison's we have hyponatremia. So now with this one we're not retaining that fluid. We are at greater risk for postural hypotension. Syncope comes along with postural hypotension. And then, of course, hypovolemic shock. And look at this man, it's thin. That decreased sodium can also cause dizziness and confusion. And remember when we were doing a fluid and electrolyte imbalance, we were talking about hyponatremia and altered mental status, which hyper can also cause. But confusion is an early sign of hyponatremia. Neuromuscular irritability. Now, if our sodium is low, our potassium is high. What's the biggest danger of high potassium? Cardiac dysrhythmia, life-threatening cardiac dysrhythmia. Because our cortisol is low, we have hypoglycemia. Remember the other one was hyper. Lethargy, weakness, anorexia, nausea, vomiting, and diarrhea. And that adrenocorticotropic hormone is what causes the hyperpigmentation. So now look at this. We have weight loss, hyperpigmentation. Hypotension is very important because that could be life-threatening. We have fatigue, postural dizziness and syncope go hand in hand with hypertension. Very could be very serious. All right. If the Addisonian problem is not taken care of, they can have, or any of these triggers, they can have a crisis, which also is life-threatening. The triggers: surgery, an acute systemic illness, trauma, or, once again, abrupt withdrawal from long-term corticosteroids. Okay. The manifestations: high fever, weakness, severe pain to abdomen, lower back, severe vomiting and diarrhea, and what's going to bring this into a life-threatening situation, cardiovascular collapse. What happened? Okay. Severe hypotension and circulatory collapse. That's going to be the main life-threatening issue. So if we're having cardiovascular collapse, what are we going to do? Fluids, IV fluids. and your glucocorticoids replacement, which is your corticosteroids. Okay? Alrighty. I encourage you to look at this. It's basically everything I've already told you. If you look at it, but the more you look at it, the more it's likely to stay in your brain. Okay, your diagnostic tests are going to check your cortisol levels, and of course we already said that this is a deficiency. The other one was increased. Remember we said that your blood glucose is people have hypoglycemia and hyponatremia. Hyperkalemia, now the ACTH levels, just like the other one. These are increased in primary adrenal insufficiency and decreased in secondary adrenal insufficiency. The ACTH stimulation test, you need to know, is the most specific for Addison. The most specific. With the ACTH stimulation test, the cortisol levels will increase if it is a pituitary deficiency stimulating the adrenal gland, and there will be no rise if it is primary coming from the adrenal gland. The medications, which is what you were saying, Robert, you give them the corticosteroids and it takes them out of that. So if somebody stopped their corticosteroids abruptly, you would treat the symptoms, the ABCs, and part of your treatment would be to administer corticosteroids and wean them off slower. Okay? You have corticosteroids, hydrocortisone, and you have mineral corticoids. This one has your minerals, your sodium. Nursing care. Because of the hyponatremia, they have fluid volume deficit. And that's what's causing the hypotension, postural hypotension. They still are going to be in strict intake and output, bless you, because you want to know if they're losing more volume. You're going to increase fluid intake on these people. Look at how much, 3,000 milliliters per day. And one of the few times you tell people to increase sodium intake, right? Because for all, you're always telling them, stop that salt, don't take so much salt. But this is one of the few times you have them increase sodium intake and decrease potassium intake. Because it's fluid volume deficit, you're going to monitor for signs and symptoms of dehydration and monitor for cardiovascular status. A lot of teaching needs to go into these patients, medication. This is one of the times that these people are told to change their medication dosages depending on what's going on in their life. Because usually we don't tell people to do that. They should have a medical alert bracelet and they should have corticosteroids with them. Because they need to know to take it when they have the impending problem. And that is right here. Carry emergency cortisone parenteral administration. Because of the postural hypertension, sit and stand slowly, and they have to keep their appointments, they have to keep their monitoring process, they have to keep everything going. And I thought it was interesting that President Kennedy had Addison. All right, question number 1. Which nursing diagnosis should the nurse document in the plan of care for a client nursing diagnosis? This, in a client diagnosed with Cushing syndrome, select all that apply. Fluid and electrolyte imbalance related to hyperkalemia and hypernatremia. All right, good job, good job. Body image disturbance related to weight gain and facial hair. Risk for infection related to decreased inflammatory response. Risk for injury related to weakness and fatigue. Disturbed thought process related to mood swings and irritability. You guys go. How could I forget my candy? So, rationale. All nursing diagnoses should be included except fluid and electrolyte imbalance related to hyperkalemia and hypernatremia, because the electrolyte imbalancing in Cushing syndrome is hypokalemia, not hyperkalemia. A nurse's assessment of a client diagnosed with Cushing syndrome includes the following findings. 4+ pitting leg edema, you're expected to see that, right? Blood glucose 140, irregular heart rate, and ecchymosis on the right arm. Which action should be taken by the nurse first? Go back and read the question carefully before you make your decision of 1, 2, 3, or 4. So read your assessment data. Now, first, would you weigh the client first? Would you administer insulin first? Would you notify the physician first? Would you measure the client's abdominal girth first? Why are you going to notify the physician first? Heart rate. Heart rate. Good job. Good job. What are you considering? Cardiovascular, and what electrolyte? Potassium. Potassium. Good job. I'm so proud of you. All right. Cushing syndrome causes overproduction of aldosterone, retention of sodium and water, and excretion of potassium. An irregular heart rate can occur from hypokalemia. The physician should be notified immediately to obtain, because you need an order, to do a serum potassium level and treat the irregular heart rate and hypokalemia at present. The other actions are appropriate for Cushing syndrome, but the first action addresses the major problem. Good job, guys. Which clinical change should indicate to a nurse that the therapy for a client with Addisonian crisis is effective? How many say 1? That would be the 1. Remember, they're the ones with the postural hypotension, the low sodium. An increase in blood pressure is indicative of effective therapy. Addisonian crisis is caused by adrenal cortical insufficiency with disturbances of sodium and potassium metabolism resulting in hyponatremia. The depletion of sodium and water causes severe dehydration and hypotension. Question 4. Which medication should a nurse plan to administer to a client admitted in Addisonian crisis? 4. Everybody better say 4. 4. Now, this one is used to treat, but not this, right? Okay. And the priority would be your corticosteroid replacement. Addisonian crisis results from insufficient secretion of glucocorticoids and mineralocorticoids from the adrenal cortex. Hydrocortisone is a corticosteroid used in the absence of sufficient glucocorticoid production. And your ketoconazole is for Cushing. And I think that's it. Hot, is it hot outside? Shut up. Poor baby, look at her. Well, guys, I am planning to have a review next Friday, and I will have, it'll probably be around the same time, and I'll just post it. And what I encourage you guys to do is to have all of your PowerPoints, because I'm not going to have to still upload every single PowerPoint. So they're going to be the exact same ones we've used all through the semester, and I'm just going to go through highlights of everything that you need to be aware of or remember. Thank you. And we are done, Miss
Mommy that tells me that with my dog, she has absence, that you have to add the steroid.
Oh, and remember?
No. I mean, she gets it added to it.
Oh, that's a good one.
Yeah.
That's totally in front of everybody. I'll try to
Oh,
remember it
well,
for the review.
I love to interrupt you sometimes.
Try to remember it for the review.
Thank you very much.
You're welcome.
My fault.
Are you going to ask about the hypoglycemia?
Yeah.
I want to know the answer too.
The hypoglycemia for that after, right? I thought it was about the infection too.
Yeah, but it wasn't. And then we would have like then you would have increase with the infection, right? The white blood.
But you had said hypoglycemia. That it was.
I mean infection.
Okay. So it's like you're quite your alarm.
How are you?
Without checking.
No,
Without checking.
We made it without checking.
Can't survive without it. Hi, Robert. You good? Make sure you guys sign in, okay? I need your signature on the sign-in sheet, too. Yeah. You're welcome. Thank you.
thank you.
Oh, question.
My question was about the infection, the risk for infection, and the one with hyperthyroidism.
Was it hyperthyroidism?
Yes.
Hyperthyroid.
So you said something about it. Was it because of the neutrophil, and then you said no, the neutrophils are usually
Decreased.
no, she said elevated.
I have to go back and look at my slide to make sure I didn't make a mistake on the slide. But
It's even like in the box right here. Monitor.
Because you have a reduction in neutrophils.
And don't you have an increase when you have a
you do have an increase to fight your infection, but you're at risk for infection with decreased neutrophils, neutropenia.
Okay.
Okay? So, side effect, agranulophytosis. So, agranulophytosis means that you increase, but you will have a decrease. Okay, but this is secondary to these drugs.
To this drug, and it's actually the,
Okay.
I think in the past though, like it had nothing to do with the, nothing extra.
Okay, hyperthyroid. Let me get my brain working here. Hyperthyroid increases
Oh yeah, I just told you like your name, your
No, I think it's just related. I have to go back and do my part one, but I don't want to touch it because she's
no,
done.
that's okay.
It's just related to the drugs.
To the drug.
Because see, if you look here with hyperthyroid, it usually has, like, if they affect your immune. And if you notice, there's nothing there related specifically to the immune. So it's related to the side effects of the drug.
And it would be the
No, antithyroid.
okay.
PTU. The PTU.
I have another question,
Yes.
and that will be for the. Okay, for the person who has the Cushing syndrome, does that person take insulin and diuretics?
Cushing syndrome.
Since they always have hyperglycemia?
They actually, you know what? That's a good question because a lot of these patients are diagnosed with diabetes. And so they will take either insulin or something definitely to bring the blood glucose.
And then they diuretics because of the edema?
The diuretic, usually if you can control the sodium, you may or may not need the diuretic because they're not used that often.
And in response to
Let me double check, but if we look at Cushing, there are medications that are often used do not usually include diuretics because once you control the cortisol and sodium,
so I guess that would be the same thing applying for the insulin. If they can control it with medications, then they don't have.
but in the meantime, they do take it. In the meantime, because a lot of these people are actually diagnosed with diabetics before they're diagnosed.
That was my